According to Canadian Cancer Society, breast cancer is the most common cancer and the second leading cause of death from cancer in Canadian women. 1 in 8 females in Canada is expected to be diagnosed with breast cancer in their lifetime. In 2022, estimated 28,600 Canadian women will be diagnosed with breast cancer, and this number represents 25% of all new cancer cases in women. Moreover, estimated 5,500 Canadian women will die from breast cancer in 2022, and this number represents 14% of all cancer deaths in women. On average, 78 Canadian women will be diagnosed with breast cancer every day, and 15 Canadian women will die from breast cancer every day. In order to find breast cancer early, when women have the best chance of being cured, Canada began screening mammography in 1989. According to Statistics Canada, breast cancer mortality has been reduced by 15% in the last 10 years because of the organized screening, early detection, and effective treatment. So, what is cancer screening? Cancer screening is testing done on people who may be at risk of getting cancer, but who have no symptoms and generally feel fine. Screening can find breast cancer when they are small, less likely to have spread, and more likely to be treated successfully. In Ontario, the government provides breast cancer screening by mammogram every 2 years for most women whose ages are from 50 to 74 years old. Women who are less than 50 years old can only go for screening when they have risk factors like family history and radiation therapy. So, there is a huge healthcare issue of no access to breast cancer screening for women under 50 years old without risk factors. There is a disparity between breast cancer screening practices in Canada and the severe outcomes of breast cancer in women under 50 years old. In 2021, 17% of new cases of diagnosed breast cancer and 21% of deaths of breast cancer are from the age group under 50 years old. Wilkinson and her colleagues from Ottawa University found out that for the 2010 to 2017 period, women aged 40 to 49 were diagnosed with lesser relative proportions of stage 1 breast cancer, but greater proportions of stage 2 and 3 breast cancer compared to women aged 50 to 59. In addition, women aged 40 to 49 without jurisdictional screening, like in Ontario, had higher proportions of stage 2, 3, and 4 breast cancer compared to women with jurisdictional screening, like in Alberta. Survival rates decrease in relation to the more advanced stage of breast cancer at diagnosis. The 5-year survival rate for stage 1 breast cancer is 99.8% compared to 74% for stage 3 and 23.2% for stage 4 breast cancer. Therefore, if breast cancer screening is only available for women over 50 years old, at least 4,690 young women would miss the best time to find the breast cancer early and the best chance to be treated early, and over 1,000 young women will die unnecessarily that could be saved by screening in Canada each year. As a result of no access to breast cancer screening, young females with breast cancer may experience a relatively poor prognosis, greater impact on life expectancy, more advanced stage at presentation, and higher prevalence of unfavorable tumor features compared to the females over 50 years old. However, all those outcomes can be prevented or early found by just providing breast cancer screening to women under 50 years old. The Canadian Task Force has published guidelines for breast cancer screening recommended against screening women aged 40 to 49 since 2011. Therefore, now it should be the time to address political action to change the breast cancer screening guidelines for young women in Canada, because those guidelines are already outdated and inconsistent with more new evidence, which show that women aged 40 and over who actually participate in screening have a greater reduction in deaths. In addition, the Canadian Task Force guidelines state overdiagnosis is a harm in breast cancer screening under 50 years old, because young women are diagnosed and treated with cancer that never would have harmed them. However, cancer won't disappear without appropriate treatment, and it is misleading to advise women that they should delay screening until age 50 to reduce overdiagnosis, since these cancers, if they even exist, will still be detected at age 50. Delaying screening will not avoid overdiagnosed cancers, but women will die unnecessarily if screening is delayed. Finally, most recently, fundamental errors in the Canadian National Breast Screening Studies have been confirmed. The Canadian National Breast Screening Studies have been major outliers among the randomized controlled trials of breast cancer screening. Unlike other trials, they fail to show any benefits from mammography and clinical breast examination screening for women aged 40 to 49. Since the Canadian National Breast Screening Study's initial publication, there has been a weight of evidence questioning study protocol validity, particularly the likelihood of compromised randomization, like assigned women with more advanced cancers in non-random order to the screening arms. Almost all the studies for formulating breast cancer screening guidelines are based on Caucasian women. The incidence of breast cancer in Caucasian women peaks in their 60s, but the highest incidence for Black, Hispanic, and Asian women are in their 40s. So, the Caucasian population doesn't have force and motivation to change the breast cancer screening guidelines, since they are least influenced. Current screening guidelines need primary care referral for screening young women, even with a high risk of family history. Therefore, most young women cannot have the access to breast cancer screening if their health providers cannot provide referrals. According to Statistics Canada, the cost of annual mammography screening for a woman has been estimated at $2,355. The overall healthcare system cost for annual screening per 1,000 women ranged from $7.4 million for women aged 50 to 69 to $10.7 million for women aged 40 to 74. So, rejecting breast cancer screening for women under 50 years old can save almost $3 million per 1,000 women for the government each year. All women can have a chance to early detect breast cancer to prevent late-stage cancer. The families can have less emotional and economic stress for taking care of women with late-stage breast cancer. Healthcare providers can save more women's lives by treatment of earlier stage cancer. Public health can decrease the risk of late-stage breast cancer in young women, and policymakers can generate the necessary political will to support the change, and the government can shape healthcare through legislative policies and budget allocation. Because the Canadian national breast screening studies have been proved unreliable and biased, the Canadian Task Force guidelines are outdated and inconsistent. The federal and provincial governments should retract the Canadian national breast screening studies and update the guidelines, including self-referral for mammograms across jurisdictions starting at the age of 40 based on new scientific evidence from oncologists and other breast cancer specialists globally. The Canadian Society of Breast Imaging has recommended that women aged 40 to 49 should screen annually with mammography. However, these guidelines won't get changed until the whole medical community, individually and collectively, asks for breast screening guidelines to be updated to reflect the latest scientific evidence. To address the inequity in healthcare, education is always the most effective way. Both healthcare providers and the women population can have education about breast cancer in young women and the benefits of screening at the age of 40 to increase the awareness of the eligibility of women for screening. Advocacy is the responsibility of all stakeholders in the breast cancer community. Identifying these cancers through screening at an early stage, where associated treatment costs are reduced relative to late-stage disease, could result in substantial savings for the Canadian healthcare system. According to Statistics Canada, if breast cancer screening includes women aged over 40, the cost is about $150,000 per quality-adjusted life years for each woman, and it is very cost-effective compared to the cost of $300,000 per quality-adjusted life years if there is no screenings for the women. It takes years or decades for updating the guidelines. For evaluation of the effectiveness of the strategies for breast cancer screening in young women, the incidence of death can reflect the mortality of young women with breast cancer screening. If the risk of dying from breast cancer was reduced within 10 years of diagnosis for women who participated in screening compared to those who did not, the strategies will be effective. However, it also takes a long time. Once the breast cancer screening guidelines become the barriers of improving young women's health, it is time to take action to change now, because young women with breast cancer have waited too long time.